In this video, we'll be discussing cardiac arrest management. So let's jump straight in. Here we go. Basic life support is the foundation of all our cardiac arrest management. If we do not perform good BLS, the chance that our advanced interventions will be successful is very unlikely. The first step in the BLS sequence is to check for response. Tap and shout, "Hey, hey, hey, are you okay?" If there's no response, check for a pulse and breathing simultaneously for 5 to 10 seconds. If the patient is not breathing or does not have a pulse, immediately activate your local emergency system and start with high quality chest compressions. High quality CPR includes pushing hard, pushing fast at a rate of 100 to 120 compressions per minute, pushing down at least 2 inches or 5 centimeters, allowing full chest recoil and not interrupting CPR unnecessary. Once your crash cart or your defib arrives, immediately connect it and hunt for ventricular fibrillation or pulseless ventricular tachycardia. Immediately perform defibrillation if you see any of these two rhythms on the monitor. For every minute we delay defibrillation, the chance of survival will diminish by 7 to 10% per minute. Deliver your first defibrillation by following the recommendations of the manufacturer. Keep in mind that the resuscitation coach does not endorse any specific manufacturer, and we will reference the most commonly used devices in the market. Immediately resume high quality CPR after defibrillation. Insert an IV or an IO and prepare your first medication. We will prepare epinephrine 1 milligram of the 1 milligram in 10 ml concentration or 1 in 10,000. After 2 minutes of CPR, analyze the rhythm, and if the rhythm is still VF or pulseless VT, immediately defibrillate for the second time and resume CPR for 2 minutes. We have now given 2 defibrillations and can administer epinephrine 1 milligram IV push followed by a 20 ml normal saline flush and elevate the extremity. In VF or pulseless ventricular tachycardia, the recommendation is to administer the epinephrine only after the second shock, as we are focusing on the most important steps, which is early defibrillation and high quality CPR. At this stage, consider placing an advanced airway and using waveform capnography. Waveform capnography can help us monitor tube placement, but will also help us to monitor CPR quality. We also have time to prepare our next medication. Our next medication is Amiodarone 300 milligrams IV or Lidocaine 1 to 1.5 milligrams. If the rhythm is still VF or pulseless VT, we can deliver our third defibrillation. Immediately after defibrillation, resume CPR for another 2 minutes. After the third shock, we can administer Amiodarone or Lidocaine IV push. Most clinicians will use the big A, but there's a lot of debate on which is better. In Circulation in 2019, a study by Wagner et al. Compared Amiodarone to Lidocaine for in-hospital cardiac arrest and found that it was not associated with higher ROSC rates, but Lidocaine was associated with higher 24-hour survival, higher survival to discharge, and favorable neurologic outcomes. In November 2022, in Chest Journal, Wagner et al. Published a comparison again and found that lidocaine was associated with higher ROSC rates, 24-hour survival to hospital discharge, and favorable neurologic outcomes. So let's see what the updates will be when the 2025 AHA guidelines will be released. Currently, as per the AHA guidelines, you can select any of the amiodarone or lidocaine. We should also never forget to consider our reversible causes of cardiac arrest, or our HSSTs, as listed here. At this stage, get ready for another dose of epinephrine, 1 milligram. After our 2 minutes of great CPR, we need to defibrillate again if indicated. And continue high quality CPR. After the fourth shock, we can administer the second dose of epinephrine 1 milligram IV push and start preparing amiodarone, this time 150 milligrams, or lidocaine at 0.5 to 0.75 milligrams per kilogram. After our fifth shock, we can go straight to administer amiodarone or lidocaine, and again it's IV push, followed by a flush. Again, take note of the lower dose, amiodarone or lidocaine. In the VF or pulseless ventricular tachycardia algorithm, we follow the following pattern. Our initial priority is high quality CPR and defibrillation. We will only give our first epinephrine following our second shock. After our third shock, we'll give amiodarone or lidocaine. After our fourth shock, we will give another epi. After our fifth shock, it will be amiodarone or lidocaine again. If you select either amiodarone or lidocaine, keep using it, as antiarrhythmics can also become proarrhythmic. The way I remember the Shockable algorithm is to give epinephrine after the equal number of shocks and amiodarone or lidocaine after the odd number of shocks. By following this pattern, you will give one epi every 4 minutes and one amiodarone every 4 minutes, which is within the AHA guidelines of giving epi or amiodarone or lidocaine every 3 to 5 minutes. Let's review our non-shockable cardiac arrest rhythms. Here we see our two non-shockable cardiac arrest rhythms. The treatment for asystole and pulseless electrical activity is the same. If you find asystole, please confirm that it's a true asystole. Do a flatline protocol. Check the ECG leads and ensure that your defib is set up correctly. What is a PEA? It's an organized rhythm on the monitor without a detectable pulse. High quality CPR is indicated for both. Immediately get an IV or IO access and prepare your first medication, epinephrine 1 milligram. We can give epinephrine 1 milligram IV push every 3 to 5 minutes. In asystole or PEA, we want to give the epinephrine as early as possible, as it's been shown to improve return of spontaneous circulation or ROS. So don't wait like what we do in VF or pulseless ventricular tachycardia. Consider an advanced airway with waveform capnography, and don't forget the reversible causes of cardiac arrest. I get asked a lot about mechanical CPR, which is a hot topic. So what does the American Heart Association say in their 2020 AHA guidelines for CPR and ECC? The routine use of mechanical CPR devices is not recommended, and that's a class 3 recommendation. They do, however, say that the use of mechanical CPR devices may be considered in specific settings where the delivery of high-quality manual compressions may be challenging or dangerous for the provider, as long as the rescuers strictly limit interruptions in CPR during deployment and removal of the device. And this is a 2B recommendation. In my opinion, mechanical CPR devices definitely have a place in our workflow. Using mechanical CPR devices in specific circumstances, like where high quality chest compressions cannot be safely delivered, may be a reasonable strategy. I'm thinking in the back of a moving ambulance, in the back of an aircraft due to very limited space and limited manpower, infectious diseases, to minimize the number of healthcare providers put at risk. The pandemic was a good example where we could consider the use of mechanical CPR. In a situation where you're working in rural EMS, where there is not enough manpower to manage cardiac arrest, freeing up hands to manage other tasks, and considering its use in the cath lab. In all situations where mechanical CPR devices are used, clinicians must ensure that the device is deployed with minimal interruption to chest compression delivery. If you benefited from this video, kindly like, subscribe, and smash that notification bell. We'll see you in the next video. Have a fantastic day.